Okay, we'll get started. So welcome everyone to today's session. The title of today's webinar is Culture Matters in Mobilizing ACP. This is part 2 of the ACP webinar series that began last week, where we had Drs. Howard, Dr. Sussman, and Dr. Castellanen speaking to us. Today we are pleased to have Dr. Gloria Gutman joining us, as well as members of the Diversity Access team from the Simon Fraser University Gerontology Research Center. So my name is Jeanette Prorock, and I will be the host for today's webinar. Following the completion of the presentation, we will answer as many questions as time permits. If you're not familiar with Zoom, you'll see there's a Q&A button at the bottom of your screen. Please feel free to enter your questions there throughout the presentation, and we'll pose them to Dr. Gutman and the panel at the end of the presentation. A reminder that the webinar slides and video are available for viewing online within 1 to 2 days. Following this webinar, we invite you to share this widely with your colleagues and your networks. The webinars can be found at www.cfn-nce.ca/webinars. And as always, we encourage you to monitor our website for updates at that same website. The cfn-nce.ca/webinars is where we have all of our upcoming webinars. Our next one is actually next week on March 3rd. Please note the change from our usual Wednesday to Thursday. So March 3rd and March 10th, we will have Dr. John Hurdes and Dr. George Heckman speaking to us about their Babel project, so better targeting, better outcomes for frail elderly patients. With that, I'll get back to today's presentation. So as I mentioned today, our main presenter is Dr. Gloria Gutman, speaking to us about culture matters in mobilizing ACP. So Dr. Gutman developed the Gerontology Research Center and Department of Gerontology at Simon Fraser University and was director of both from 1982 to 2005. She is currently a research associate and professor emerita at SFU. She is the author and owner of 23 books, hundreds of publications, and has held a number of high-profile roles, including 2 terms as president of the Canadian Association on Gerontology, the president of the International Association of Gerontology and Geriatrics, and president of the International Network for Prevention of Elder Abuse. Currently, she is president of the North American chapter of the International Society for Gerontechnology and vice president of the International Longevity Center Canada. In 2012, she was awarded a Queen Elizabeth II Diamond Jubilee Medal by the Government of Canada, and in 2016, she was appointed to the Order of Canada, the country's highest civilian honor. We're very pleased to have Dr. Gutman here today, along with her colleagues, to share with us on this very important topic. Thanks so much. Over to you, Dr. Gutman.
Thank you. I'm going to go to share screen. Whoops. Oh my. Okay. There are, for those of you who were with us last week, you will know that our project is part of the ICANN ACP project, and those acronyms stand for Improving Advanced Care Planning for frail elderly Canadians. Our vision is that older Canadians living with frailty will receive person-centered care, goal-consistent care as they near the end of life. And our mission is really to increase uptake and access to advanced care planning for older Canadians across the 3 sectors of primary care, long-term care, and hospital settings.
Dr. Gutman, just to interrupt you for a moment, sorry, I don't think we can see your screen. Could you try sharing your screen there again, please?
Okay. I don't seem to be able to get back down to, can you do it from your side?
Yep, let me just open.
Okay, hang on. Because it's, okay, let me just see. Oh, let's try it again. How's that? See it now?
Not yet, no. but that's okay. I've got your slides here. If you'd like, I can advance them.
Yeah, just put.
Okay.
What
I'll put them up right now.
need to do to escape?
There we go. I've got them there. So if you just let me know.
Okay, next slide, please.
Okay, which slide is it?
And next slide, next slide.
Yep.
Next slide. So this is the overall project. And as you see on the left column, the diversity access team, which is what our group is called, cuts across the three sectors of primary care, long-term care, and hospital care. And so we began the project with the idea of the tools that were discussed last week and that were described as having been chosen to focus on in our presentations and in our work on the basis of them being evidence-based. We began with that idea of adapting and tailoring the tools, but very early on, we realized that many people advanced care planning. And so our project evolved in a number of different ways and sub-projects, which we want to talk to you today about. Next slide, please. Next slide. The full project has 32 investigators. We've got patient advisors, we've got research staff, international collaborators, and many partner organizations. Next slide. And this is our full team. And there are a number of them with us today. There are several who will be speaking, as well as some who will be joining with us in the discussion as at the end of the presentation. Next slide. These are the facilities that we partnered with, in particular in the long-term care part of our project. Next slide. Now, the aim of our project really was to increase participation in advanced care planning in three minority groups, LGBT, Chinese, and South Asian. The two ethnic groups are Canada's largest visible minorities, each constituting up to an estimated 10%, as well as the LGBT community. And our activities in the primary care sector began with a series of focus groups with community-based LGBT seniors, with a group of men living with HIV/AIDS. And that particular study was conducted by a graduate student at McGill. We had the Chinese and South Asian seniors and their families that our team introduced. Katrina Zhang, who is with us today, was one of those who was involved in the Chinese and South Asian seniors groups, as well as Helen. What we did was to introduce the concept and get some feedback on the relevance of the tools that we were wanting to introduce people to. And in the primary care sector, we were meeting with community groups mainly. And in the long-term care sector, we did focus groups with residents, with families, and with staff in two care facilities. One of them was a Chinese facility. The other was multicultural. And these were followed by staff education sessions about ACP. And we really wanted to, in those sessions, to make sure that we all were on the same page about what advanced care planning really was all about, and about some of the opportunities and types with respect to learning about how to communicate better and what tools might be used. In the hospital sector, we did a number of interviews with both primary care physicians and with hospitalists whose practices included 15% or more of older adults from our three populations of interest. And we wanted to have both primary care physicians as well as hospitalists, recognizing that the two have different time frames in terms of when they interact with their patients, and recognizing the primary care physicians would be on an ongoing basis, as opposed to hospitalists, where people meet them for the first time when they're in critical condition. Next slide, please. So these are the three main tools that we focused on in our part of the project. So your conversation starter kit, which has a special version for people with dementia and for their caregivers, and one that was a made in BC version that was called My Wishes, My Care. And that particular one was developed by the BC Centre for Palliative Care, with whom we were partnering on some of our projects. Next slide. So in what we found from our work in the primary care sector was that advanced care planning was really a new concept for many of the Chinese and South Asian participants. And people had a hard time sort of describing or understanding where it fit. Some of them, they thought it was to do with funeral planning. Other people talked about, when we talked about documents for advanced care planning, the first thing that came to mind was their will, and thinking about how they were going to distribute their granny's teacups, the kinds of things that we each have in our homes, paintings, whatever. There are tangible goods, rather than understanding that really what we're talking about here is the care that one would want if they couldn't speak for themselves. So particularly in the LGBT focus groups with the men with living with HIV/AIDS, what came through very clearly for us was that they were preoccupied with day-to-day living. And especially in the trans population, people were concerned about just getting through the day and living with HIV/AIDS for some of them, with others with the day-to-day business of being part of a community that wasn't always welcoming. And we heard about social isolation. We heard about barriers being identified by our LGBT older adult participants. In the long-term care sector, across facilities, we had discussions about ACP, which was described as, for them, for staff, being somewhat awkward to handle. They're having limited opportunities. And in the case of the nursing aides and support staff, although many of us have said everybody should be involved in advanced care planning and in assisting the residents, in actual fact, the staff that we talked to said that it was basically within the scope of practice of the professional staff, rather than seeing it as being something that the care aides were supposed to be doing. And so some of them felt that it really didn't fit within their scope of practice, while others felt that they were somewhat hobbled in their roles of being able to assist residents because of lack of knowledge, because of their own educational needs. And in the case of our LGBT respondents and those of their loved ones that we talked to, what came through very clear was their concern of the non-kin relationships, that people who were not in heterosexual kinds of relationships being recognized as family. And it's just so important when we're working with that particular part of our population to recognize that families of choice are just so important, and that who the person feels are their family, who the person feels are their closest confidant, is who we as the care providers need to be recognizing as being so important to the life of the patient or the resident. Next slide, please. So we came to the conclusion that really action is needed to mobilize the LGBT community as well as the two ethnic groups to complete advanced care documents and to engage in conversations about their goals of care with appropriate others, and to understand that the topic is not well understood, particularly in ethnic minority groups. It's a taboo topic for many in the Chinese community. And so really the first step, if we want to mobilize and move this forward, is basic education about what ACP is and what it is not. And in the case of LGBT persons, of who can speak for them if they cannot speak for themselves, and who to provide care. So in terms of tools, the booklets that are available, and there's a lot of them around, as you will find if you know this area or if you Google. Not all of them are as good as others, but most of them are not as inclusive as they might be, both in terms of the language that's used and in terms of the visuals. So we are in this country a multi-ethnic population. We are also a diverse population in terms of sexual orientation and identity. And so that needs to be reflected so that people, when they get documents or when they get other aids to doing advanced care planning, can really identify and feel like it speaks to them. And also what came out loud and clear was that we need to think about non-traditional approaches to ethnic minorities and to the LGBT community. So it's not just your usual one-size-fits-all approach, but rather that we need to tailor our messages and how we go about explaining the concept and helping people to find tools that will help them to be able to have the conversations with their important people, and also to be able to complete the documents that will help in the case of them not being able to speak for themselves. So next slide, please. I also want to tell you about a really exciting part of our project, which was an online survey that we did to look at the people's experiences, older adults' experiences of the COVID-19 pandemic and how it affected their planning for the future. So our survey ran from August 10th to October 10th of 2020. It was a national survey that we recruited people for using social media, direct emails for those that we had an email address for within our networks. And we did quite a bit of Facebook advertising. We also had the assistance of some 85 organizations to promote and draw attention to the survey. And we were delighted that some 4,380 Canadians, literally from coast to coast and everything in between, did respond to our survey. The age range of our respondents was 55 to 99, mean age 66.9. And as you see on this slide, we had a substantial number of both males and females, although as we discovered, when you do Facebook advertising, the largest consumers of Facebook are female. So in fact, although we have more women than men in our survey, that's typical of this kind of recruiting, and something that those of you who are researchers need to keep in mind. But we also had some 21 transgender people who were part of our respondents, and have a sample of around 500 of Canadians who are from the LGBT community. And so, as you see, 1 in 10 were part of the respondents. And the survey topics had a number of questions and topic areas. One of them was sort of, were you exposed to, or had you been infected by COVID-19 or not? So we have both types of people amongst our respondent groups. We had a number of questions on the degree to which they had complied with mitigation recommendations from the Public Health Agency about social distancing and about wearing masks and so on. We had a number of questions about their how it affected their health and lifestyle, what changes it had made. We asked about its influence on social support, and particularly of interest for this presentation today, we asked some questions about advanced care planning, both what they had done about it before the pandemic and after. Next slide, please. So in terms of document completion, what we see is some about 65% of the respondents had prepared a will. And then they had prepared documents having to do with their property distribution, with some 27% about medical kinds of things. We had a small percentage who had done advanced directives. But in actual fact, what we found, and much to our surprise, because we thought that the pandemic would be a motivating factor, that since the onset of the pandemic, only 3.2% of people had prepared or revised any of the documents that they had done before. But on the upside, some 43% had engaged in some care discussions since the pandemic outbreak. So it motivated discussion, but it didn't motivate people to take the next step, which was to actually put on paper what they wanted in the way of care should they have a serious illness or be unable to speak for themselves. Next slide. In terms of overall findings, what we found was, much to our surprise, that the negative impacts of the pandemic were greater in the younger old, in the 55 to 74 age group. They were more severe for women, but the good news was in terms of sexual orientation, that the LGBT people within our sample seem to have taken the pandemic more seriously and prepared for it in ways that were over and above what their heterosexual colleagues had done. And in terms of planning for the future, what our survey found was, although the effect generally was most on the younger old in terms of disrupting their routines and things, it was the older old who, I guess because they're closer to being influenced by the pandemic in a negative way, were the ones who did actually take it seriously. And so they were more likely to have moved forward with advanced care planning than the younger ones. And as we might have expected, prior to the pandemic, women were more likely to have completed ACP documents. I say it was expected because in general, women tend to be more compliant with these kinds of things than men. So both before and after the outbreak, the women were 2 times more likely than men to have had ACP discussions with family. So that's one of the things to remember when you're talking with older adults, to make sure that we get both the men and the women, but to spend a little extra time in telling the or in helping our older adult males to understand that this is something they should be concerned about. And we found with both prior to and after the outbreak of the pandemic that our lesbian, gay, and bisexual respondents were more likely to have had discussions than their heterosexual respondents. So both before and after were more likely to have taken the pandemic seriously and thought about what it meant in terms of what their life might be like. And we think from some of the other work that we've done in other parts of the survey that part of this is because of their experience in having lived through the HIV/AIDS epidemic. So they had that was a difficult time for our older adults within the LGBT community, but having survived it gave them some skills or some confidence and may explain some of the resilience that we see in this community. And certainly my colleague, Brian DeVries, who is with us this morning, can speak to that part of our findings and has written some or led us into write some interesting articles, which I would draw your attention to on our findings. Next slide, please. So amongst the things that surprised us in the survey was that only 5% of older Canadians had ever had a care discussion with their doctor. We sort of began from the premise thinking that that would be the logical person who people would talk to, since we're talking about care rather than granny's teacups. But what we found was that really quite a small percentage. So this led us to the next steps within our research program, which involved doing some interviews with physicians to try, because the project, we had talked with seniors and their loved ones, but the other side of care discussions really have to be with care providers. So we wanted more information on that. Next slide, please. So that brings me to the next part of our presentation, and I wanted to introduce you to three of the students who have worked with us throughout this project, and for whom there were specific sub-projects that they had responsibility for. And one of these was an undergraduate honors thesis, where the student increased our sample of physicians from the South Asian community and explored their experience. And she's going to talk to you in a minute and tell you about her work. There was a second student who was the winner of a CFN Summer Student Scholarship and who extended our work because the survey was mainly people living independently in the community. In her project, we had a sample of people from assisted living and from seniors housing. And so we could look at and find out a bit about how people in that midpoint of the shelter care continuum were responding to the pandemic. And then the third project I'd like you to hear about this morning is one that's still ongoing, where two students in the University of Toronto Department of Occupational Therapy master's program are doing their graduate research project focusing on occupational therapists and the extent to which they think advanced care planning is part of their scope of practice. So next slide, please. I'd like to now call on Avantika Vashisht, who will talk to you a bit about what she did in her BSc honors thesis. Next slide. Okay, Avantika.
Yeah. Hi, everyone. I'm Avantika. I'm just going to walk you through some of the results and key findings of my project. So data for my research actually came from interviews that were conducted with physicians that had a practice comprising of 15% or more South Asian older adults. And these interviews were conducted at 2 points in time, so between January and to April in 2020, and the second set was over the months of May to October 2021. And during the 2020 interviews, the study participants could choose to have their interviews conducted in person, online, or over the phone. However, in-person interviews were precluded due to COVID-19 during the 2021 interviews. And the resulting data for this interview came in the form of the transcripts, which were thematically analyzed using code books, and comparisons were drawn between both primary care and hospitalists, as well as between physicians that were interviewed in 2020 and 2021. And so each of the physicians was asked 4 questions, which we can see on the table here. And the first question was aimed to understand the physician's experience when engaging in advanced care planning with this population and the impact of culture. And the second focused on tool use and the barriers and facilitating factors of these tools with the South Asian population. And the last 2 questions were added to the 2021 interviews, and they focused on the impact of COVID-19 on the physician's practice and ACP engagement. So if we could move on to the next slide, please. So physicians from the study reported that they often take on the role of educating patients about their rights and decision-making process, and they're burdened with initiating and introducing ACP discussions. And they stated how they've never seen a patient who would themselves bring up the topic. And this reluctance to initiate discussion could be due to the fear of disagreement and its negative impact on their relationship with physicians. And this may account for the decreased engagement. Physicians in this study also reported that cultural and communication barriers are common, and that the physician specialty, South Asian older adults, lack of ACP awareness and their deference of decision-making onto the family or the physician as some of the key barriers to South Asian engagement in advanced care planning discussions. So physicians in this study reported lack of time availability as one of the main barriers in engaging in advanced care planning discussions with their patients. And they stated that they wish they had more time to have deeper conversations, and how they also went on to state that advanced care planning discussions are time consuming on their own. And usually the physician does not have the time to carry through the conversation. And so they'll initiate it and then they'll send the patient home to think about and discuss with their loved ones. Physicians also reported that South Asian older adults lacked awareness of advanced care planning and were less likely to engage in ACP discussion compared to the white individuals, as the concept of ACP is not as common amongst the South Asian population. And additionally, physicians also reported that South Asian older adults have an increased tendency to deflect their decision-making onto physicians, and that this transfer of decision-making power onto the physician is not out of fear or trust, but it's a default decision due to their lack of knowledge of ACP. And another key finding was that majority of the physicians in this study reported no change in engagement and acceptance of ACP discussions due to COVID. And one notable reason for this was that these discussions were infrequently conducted prior to the pandemic, and the physician had even less time to conduct them after. And also in the hospital setting, the currents of ACP discussions did not change during the pandemic because hospitalists generally see sick patients who are in need of ACP discussion, and this presence of sick patients did not change during COVID. And furthermore, we also determined that ACP training and tools use was not very common for the physicians serving the South Asian population. We'll move on to the next slide.
Okay, our second speaker is Paneet Gill, and she's going to talk to you about her project. Paneet.
Hi, everyone. So in this study called COVID-19 Pandemic Experiences Across the Shelter Care Continuum in BC, like Gloria said, was an extension of our national survey, but we focused on specifically 3 dwelling types in BC because of the regulations for what is defined as seniors housing and assisted living across Canada differs. And so our objective was to compare the impact of the COVID-19 pandemic on the self-reported health and lifestyle of community dwelling, seniors housing, and assisted living older adults, as well as to explore the advanced care planning completion rates amongst these 3 groups. So instead of cutting by sexual orientation or ethnicity, we focused on dwelling type. We found that there has been a lot of information collected on the impact of the pandemic on Canadians living at the 2 endpoints of the shelter care continuum. So that's those living in the community and in long-term care, but information is limited on the pandemic's impact on older adults living at the midpoint of the shelter care continuum, which is seniors housing and assisted living. So we hypothesized that engagement in advanced care planning discussions and document completion before and after the pandemic would increase as we move across the shelter care continuum from community dwelling to seniors housing to assisted living, with the rationale being that assisted living residents are the most frail and of the 3 groups and would experience the greatest pandemic-related restrictions affecting their social interaction and daily routines. So here I showed my numbers on how many we recruited from each of the 3 dwelling types, and I won't go too much into the search strategy because it was the same survey Gloria spoke about before, but for the seniors housing and assisted living sample, we offered paper surveys as well, given that we knew there might be barriers in accessing our survey online. So next slide, please. And what we found was that the COVID-19 pandemic appeared to have the greatest negative impact on the routines of community dwelling older adults, and this was followed by assisted living residents, with seniors housing residents being the least impacted. So this may be in part due to a higher proportion of the community dwelling older adults still in the workforce and a greater percentage living with family or others during the pandemic at home, which may have contributed to the heightened disturbance of routine in this group. And then with respect to COVID-19 protocols, all three groups reported complying with social distancing guidelines most of the time, but mask use and socialization guidelines were adhered most by seniors housing and assisted living residents. And this possibly shows the successful mitigation strategies that were employed by the residences themselves and a need to follow safety measures more strictly, given that physical distancing is not always possible to maintain in these care settings. And then with regards to advanced care planning, assisted living residents reported higher advanced care planning document preparation and had greater discussions with the physician before and after the COVID-19 outbreak compared to community dwelling older adults. So it's possible that resources emphasizing the significance of advanced care planning engagement were distributed more widely in these settings as compared to community dwelling older adults. And next slide.
We'll now call on Katrina Zhang, who with her colleague Ellie Pizzuto are engaging in an interesting project with OTs as part of their master's program. Katrina, next.
So much. Oh, sorry. Thanks so much, Gloria. As mentioned, my research partner Ellie and I were student occupational therapists, so that explains why we're so enthusiastic about occupational therapy. So the objective of our sub-study is to explore the Canadian occupational therapists and their perceptions of their role in ACP with older adult clients 55 plus, particularly those who are Chinese, South Asian, and LGBT plus in a clinical setting. And for the purposes of this segment, in an occupational therapy or OT context, we refer to patients as clients. Although physicians historically are the healthcare professionals who conduct these conversations, we strongly feel that OTs can play a large role in this, and we're excited to add their perspective as a sub-study to all the great research that has been coming out of the ICANN ACP national study. And we feel that there's an overlap of client-centered values between occupational therapy and ACP. And as a result, we feel that OTs are well situated to facilitate ACP discussions. And while the Canadian Association of Occupational Therapists, which is our professional board, released a position statement on the importance of the role of OTs in end-of-life care, this role isn't really well defined, and there's limited research on the relationship between OTs and advanced care planning. So for our sub-study, we're employing an interpretive qualitative study design involving 30 to 60-minute semi-structured interviews that are one-on-one with OTs from across Canada. Recruitment occurred through newsletter advertisements, provincial research callouts, OT networks, and snowballing. And to date, we have 19 completed interview OTs from Western Canada and 30 completed, interviews from Eastern Canada. And this morning, we actually just booked our last Western OT, so we're now at a sample size of 50. Okay, next slide, please.
So while we have not completed our data analysis, the following is based on the preliminary findings and reflections throughout the data collection process. So to start, many OTs defined ACP outside of a medical context and brought a more functional and occupational definition. Many noted that they do not engage in the medically related elements of ACP, as it is not within their scope of practice. Many OTs indicated that they work with social workers or within interdisciplinary teams when engaging in ACP, as there are predefined rules of what elements of ACP are discussed with various professionals. Many OTs also noted that they felt more comfortable having ACP discussions with more years of experience, unique practice experiences, key mentorship opportunities, or with their own personal exposures to death and end of life. Many OTs noted that they were able to meaningfully engage in ACP discussions with older adults and their caregivers, despite cultural and language barriers, by engaging in reflective practices to ensure they are not making assumptions, as there's diversity within diversity. Engagement in ACP is context specific. Examples include increased restraints in acute care due to time versus the increased amount of time allotted in home care. In terms of provincial differences, Western OTs are more likely to cite the use of tools such as the Serious Illness Conversation Guide or Burton Goals of Care versus Eastern OTs who are less likely to use ACP tools. Many OTs who did not use tools also anticipated that lack of access to translated material may pose a barrier to many Chinese or South Asian older adults. Others noted the importance of having less gendered language for more inclusive materials for those with the LGBT plus community. Another thing that we noted is the diverse definitions of ACP by OTs based on practice context. For instance, acute care OTs would often equate ACP to discharge planning, while others would equate it to comfort care or aging in place. Definitions of ACP could also fall into a cultural context, as OTs acknowledge that values of functioning may differ. For example, some older adults may value their functional independence, while others would choose to defer their self-care activities to family, often as a cultural expectation. Many OTs also noted that language differences and lack of translation tools make it difficult to engage in ACP. There was a split in many OTs who would opt to use family or translators for those conversations, as use of either was very dependent on whether the OT felt that the family could objectively translate parts of the conversations. Lastly, we would like to share that advocacy was a major role of OTs in ACP in highlighting and amplifying the voices of their older adult clients. This was often explained within a cultural context that the needs of the family may differ from those of the clients. And so OTs would ensure that the client's values and goals are recognized and considered in ACP discussions. Next slide.
Next slide. Well, this gives you an overview of the project to date and the number of people that have been involved. What is not yet added into this table are those who participated in these 3 projects that you have just heard about, as well as a couple of community groups with whom we did an educational intervention. And so our educational part was both with staff in long-term care, as well as with the Jewish Seniors Alliance peer counseling program. And the quirky educational intervention was speaking with a group of creative writers who are also older adults who are part of the LGBT community. So this has been a very diverse, to say the least, project. We have diversity within our own research team, as you can see from the people that have spoken with you. And now I would like to call on our project coordinator. Next slide, please. Shima Sohilapur, who is going to give a bit of a summary of where we see culture and what we consider to be culture when we're talking about the context of ACP. Please. Shima.
Yeah, thank you very much for great presentation through our DAT team. I just spent very few minutes to summarize what we got and how we are really apply and use these results for the future of the ACP conversation with the focus of the culture and the relationship with ACP. Even though, as you, Gloria Gutman mentioned, we have brought up a lot of different groups and investigated the ACP concept through different type of the cultures. And we also investigated the ideas and perception from other members in the community in the healthcare system to be able to explain all the barriers, facilitators, and the future of ACP through these specific minority groups. However, even though each study and each part of finding can stand alone and bring up a lot of information and introduce great ideas to the current knowledge, however, we are thinking to look at the culture and the relationship with ACP through the multidimensional and multidisciplinary effort to be able to explain the current uptake and using of ACP through different cultures. As you learned, we had 3 groups in our study: South Asian participant, the Chinese participant, and LGBT participant, that each group has already shared a specific characteristic related to their culture or because of the specific ethnicity. However, if we look at the definitions that we have here, that they are talking about ethnicity that refer to those who may share some of the elements, including the culture, religion, race, language, or place of origin. And as we see, culture is still part of the characteristic that explain the ethnicity. However, we would like to look at the culture in a bigger picture and bigger dimension that bring us to the definition of understanding a system of ideas, rules, meaning, and ways of living and thinking that are built up, shared, and expressed by a particular group of people. Even though specific groups may have other factors that may consider their behavior and their thinking, such as ethnicity, but the culture, but we believe that the culture could affect the way of their thinking. And because of that, and we are thinking that it is not only a single culture or individual culture that could affect the way of thinking. Because of that, we bringing our approach to analyze this data and look at the data and look at this relationship, ACP and culture, through a new lens. That we are referring to culture confluence, that we bring a multidisciplinary cultural process that influence the uptake of ACP. This approach has been already introduced to the literature and to define some other health behaviors and some other activities that it's happening through the health research. And we are adopting the confluence of the culture model to explain our results and brought up a new vision to looking at our data. Next slide, please. So as you see here, we can look at the culture through different aspects, and it could be included the culture of the individuals and group culture that identify and informs how a patient live and how they die. It could be affected with the only individual, or we call it patients or community member beliefs, as well as maybe the effect that their family members and the group who are living with them may bring up to them and give them some ideas about their decision-making, their treatments, intervention, and something that they value and they would like to have or prefer at the end of their life. However, these decisions and behavior could not be happen in isolation. There are other groups and other type of cultures that could contribute and could affect their decision making, including the larger social culture, the society, the community that people are living there. It also could affect and brought up more views and knowledge to them that will affect their decision making at the end of their life. Another type of the culture is culture of medicine, culture of health system, how health system will really react or introduce the treatment, the intervention, share information with the patients. In our study, we have included different groups different groups of healthcare professionals, including primary care physician, hospitalists, occupational therapists, that they are all directly or indirectly are involved in decision making. And it is important how they approach and how they really start the conversation and introduce the ACP to their patients and those who serve. And lastly, the culture of institute. For those who are living in the long-term care facilities or as we already mentioned, senior housing or different part of the communities, how the institute will be regulated, how the people who are working there, like staff in the community, their culture, their sexual orientation, their knowledge and their training who have received based on the level of understanding and maybe possibility of lack of understanding because of the dementia, and how they can manage this situation. There are some of the very, very important factors that could affect the decision making of the patient and of an individual at the end of life. So in terms of our next approach to bringing the knowledge and translating knowledge to the current literature, we are planning to combine all the results and bringing a new lens to explain more specifically the relationship between ACP and culture. So just stay tuned and read our literature that will be published soon.
Next slide. So for further information about this, what we think is a very interesting project, please do visit our website where you will find the recordings of other presentations and of our publications, and where you can, there's also a link here for where you can find more information on our diversity access team. So I guess we have just a few minutes left for questions and answers. And Brian, perhaps you would step up to the plate if there are some questions that come that you would like to answer, or do you want to add a few comments now?
No, thank you. I appreciated the presentation. It's great to hear all the student projects as well, but I don't want to take up time away from questions if there are, there appear to be questions that people have. So I'd like to defer to that. Thank you.
Sure. So maybe I'll just pose, I think we have time for one or two maybe. So this is a quick one. So this individual writes, I may have missed this, but did the cultural background of the physician affect the use of ACP tools and engagements in discussions? Was this analyzed?
What has come out clearly is that the doctors have said it is definitely an advantage if they are of the same culture as the patient. It definitely gives them an edge, but not all of them. A few of the doctors said, well, sometimes it works better if the information is given by somebody from outside the community, as opposed to themselves who are part of the community. So we've got both.
Okay, great. And this is just a quick one before we sign off. So an individual is asking if you could repeat how to access the toolkit and booklet for the LGBT population. So would that be on the websites that you just shared there at the end, Gloria?
Yes, we have documents that were translated into Punjabi and into Chinese. So we've got them in the different languages. But also there are some tools that have been adapted by the BC Center for Palliative Care for use by different groups. And in terms of the LGBT community, we didn't get a lot of input saying that they wanted language changes, but we are aware of those and certainly have communicated those to various of the groups that are putting out documents and saying, you know, be sensitive, understand that you use a language that is welcoming.
Excellent. Well, thank you so much, Dr. Gottman, and all the panelists joining us today. We greatly appreciate the information that you've shared and for taking the time to be with us today. So thank you again. And we remind all of our attendees that this webinar will be available for viewing within 1 to 2 days on our website. And please be sure to share with your colleagues who may not have been able to make it today. Thank you so much, everyone. Have a great day.